Good evening, everybody. We're just waiting for a few more to join us before we start. Thank you for your patience. Just 1 or 2 minutes more, and then we can start. Thank you, and a very warm welcome. Good evening, everybody, and thank you so much for joining us. And from SADA and from Kenview, a very warm welcome. I see we have most of our participants with us, and so we will start this webinar. For those that don't know me, I'm Barbara van Wyk, Professional Communications Manager at Kenview, and I look after the self-care and part of the Essential Health portfolio. Kenview would firstly like to thank SADA for your dedication as a dental association in creating opportunities like this webinar tonight, where we as a company can share new scientific research with all your members. The agenda tonight is 1 hour presentation, and then there will be time for Q&A around about for 15 minutes. Just a few house rules. As per previous webinars held by SADA, please refrain from using the raised hand, but type your comments and questions in the Q&A tab. I will be monitoring that. Your CPD certificates will be loaded to the HPCSA platform, and you will be able to access all your certificates under your member profile. The event tonight qualifies for 1 clinical CEU. And just a reminder to complete the evaluation after the webinar. Kenview is committed to realizing the extraordinary power of everyday care through science. And tonight we are very privileged to have with us Dr Nuerisha Singh as our speaker, sharing with us new science of understanding essential oils in a mouthwash. Dr. Singh qualified with a Bachelor of Dental Science at Medunsa in 2007, a postgraduate diploma in dentistry in 2012, and a master's in dental public health in 2015 at the University of the Western Cape. Her real passion lies in community dentistry, and with the focus of preventative treatments. And her latest qualification is a specialist of dental surgery in community dentistry, also at the University of the West Cape in December last year. Dr. Singh is married, she loves cooking, and together with her family, they enjoy horse riding. Welcome, Dr. Singh. We are looking forward to your presentation.
Thank you, Barbara, for that very warm welcome. And good evening to all the participants. I hope that you all enjoyed this presentation that we've put together for you. So I'm just going to share my screen quickly. Barbara, will you just tell me if it's all?
Yes, I will. It just needs to go to presentation mode.
Can you see my screen?
Yes, we can. Thank you very much.
Thank you all for joining us today for this exciting exploration into the innovative world of essential oils and oral care. The focus of our discussion will be on the new scientific advancements. Please just give me 1 second. There's something blocking my view. There we go. The focus of our discussion will be on the new scientific advancements and understanding of essential oils in mouthwash, an area that has seen significant interest in research in the recent years. Mouthwash has long been a staple in maintaining oral hygiene, providing benefits such as reducing plaque, combating bad breath, and promoting overall health. Traditionally, mouthwashes have relied on alcohol and other chemical agents to achieve these effects. However, the growing interest in natural and holistic health solutions has led to the investigation of essential oils as a potent and effective alternative. Let's embark on this journey to uncover the new science behind essential oils in mouthwash and discover how these natural wonders are shaping the future of oral health. Before we go any further, I would like to declare that there is no conflict of interest, and I am compensated by Johnson & Johnson Kenvue for delivering this presentation. References are available upon request. Today's session will explore the science behind essential oils, examining their mechanisms of action, benefits, and the research supporting their use in mouthwash formulations. We will also address practical considerations, such as formulation stability, efficacy, and safety. By understanding the latest scientific findings, we can appreciate how essential oils are revolutionizing oral care, offering natural, effective alternatives that align with the growing preference for holistic health practices. Tonight's lecture is based on a comprehensive review of scientific literature and will cover the following: understanding oral health disease and prevalence, barriers and recommendations for good oral hygiene, essential oil mouthwash, its role and benefits in oral health, clinical evidence for the benefits of essential oils mouthwash alone and as an adjunct to brushing and flossing to reduce plaque and gingivitis. Understanding oral health disease and prevalence. Let's take a closer look. Oral diseases are amongst the most common non-communicable diseases worldwide, affecting an estimated 3.5 billion people. The burden is increasing, particularly in low and middle income countries. Good oral health is essential for eating, breathing, speaking, and contributes to overall health. The pain and discomfort associated with oral diseases make concentrating difficult, can cause people to miss school or work, and can lead to social isolation. Left untreated, health-related impact of oral diseases can be severe. Unfortunately, access to oral health care is often limited due to an over-reliance on specialized care using high-tech equipment, the cost of which is prohibitive for many families and communities. Periodontal disease has been recognized as a major global public health problem due to its prevalence, economic impact on the healthcare system, and health consequences. Hence, it is cited as one of the top 6 chronic non-communicable diseases. As recommended in 2021 by the World Health Assembly in a resolution on oral health, there needs to be a shift from a traditional curative approach towards a preventative approach that includes the promotion of oral health within the family, schools, workplaces, and includes timely, comprehensive, and inclusive care within the primary healthcare system. The table highlights the prevalence of 3 dental health conditions: untreated caries of the permanent teeth, severe periodontitis, and edentulosum across global, sub-Saharan, and South African populations for the years 1990 and 2015. Globally, the prevalence of untreated caries has remained nearly unchanged, indicating persistent dental health challenges. In sub-Saharan Africa, the prevalence of untreated caries and severe periodontitis has seen a slight increase, suggesting a growing burden of these conditions. Conversely, South Africa has maintained a stable prevalence of untreated caries and severe periodontitis over the 25-year span. However, a notable trend for South Africa is the significant rise in edentulosum. Overall, some of these conditions have remained stable, though, and the regional differences underscore varying dental health challenges and the need for targeted interventions. Prevalence of oral diseases in South Africa as at 2023 from the World Health Organization is as follows. The prevalence of untreated caries of deciduous teeth in children aged between 1 and 9 is a shocking 41%. Prevalence of untreated caries of permanent teeth in people over the age of 5 years old is 27.9%. Prevalence of severe periodontal disease in people over the age of 15 years old is 24.8%. And the prevalence of edentulosum in people over the age of 20 is 8.4%. Barriers and recommendations for good oral hygiene. Let's look at an article entitled Plaque Removal by Brushing Only. And for this, we're going to be engaging with an article entitled Efficacy of Home Care Regimens for Mechanical Plaque Removal in Managing Gingivitis, a meta-review. And this review was done in 2015. This meta-review confirmed the efficacy and safety of various home care toothbrush regimens for mechanical plaque removal and gingivitis reduction in adults. The review included 59 studies encompassing 212 separate brushing exercises, all meeting the eligibility criteria and involving adult patients in good health. The scientific study shows that brushing removes only 30 to 53% of plaque. The study looks at plaque index scores by utilizing two indices, the Quigley-Hine plaque index and the Navy plaque index. Efficacy of manual toothbrushing using the Quigley-Hine plaque index. On average, the plaque score reduction across the studies reviewed was 30%. The weighted mean indicates that this average takes into account the size and the quality of the individual studies, giving more weight to more reliable studies. In this case, the true mean reduction is likely between 27 and 33%. The sub-analysis of different bristle configurations showed the plaque score reduction varied between 24 and 39%. This indicates that the effectiveness of toothbrushes in removing plaque can differ significantly depending on the design of the bristles. Now, let's take a look at the Navy plaque index. The weighted mean plaque score reduction was 53%. This means that on average, the studies reviewed showed a 53% reduction in plaque scores. The 95% confidence interval indicates that the true mean plaque score reduction is likely between 50% and 56%. The sub-analysis of the different bristle configurations showed that the plaque score reduction varied between 47 and 61%, again, indicating the effectiveness of toothbrushes in removing plaque can differ significantly depending on the design of the bristles. Brushing compliance. The data seen represents brushing compliance and is based on a study titled Toothbrushing Habits in Uninstructed Adults, Frequency, Technique, Duration, and Force by Gans et al. In 2009. Here's the summary of the findings. The study aimed to evaluate whether habitual brushing in uninstructed adults meets professional oral hygiene recommendations. These recommendations typically include brushing at least twice daily for 2 to 3 minutes with gentle force using the Bass technique or modifications of it. What were the findings? Under regular brushing, 79.6% of participants brushed their teeth twice daily. Brushing duration, participants spent an average of 96.6 seconds brushing compared to the recommended 120 seconds. Brushing force, the mean brushing force used was 2.3 newtons, while the recommended brushing force is 3 newtons. Brushing techniques, 73.8% of the cohort used a circling technique, 8.37% used a horizontal or scrubbing method, 13.6% used a horizontal circular method, 3.9% used a vertical or sweeping movements. The modified Bass technique was not observed in the participants. What are the conclusions? Only 25.2% of participants fulfilled all recommended brushing criteria, highlighting the need for ongoing oral health education. Flossing compliance. A survey of floss frequency, habit, and technique in a hospital, dental clinic, and a private periodontal practice by Segelnik in 2004. The study aim and method. The study aimed to determine the floss frequency, habits, and techniques of patients. It involved adults in generally good health visiting either a hospital dental clinic or a private dental practice, who completed the questionnaires on their flossing frequency and individual flossing habits. Some of the findings included, let's look at flossing frequency. 13.5% of participants flossed daily, 29.5% flossed between 1 and 6 days a week, and 57% of participants did not floss at all. If we look at the table regarding flossing techniques, we see the table shows the correlation between the number of times the floss moves up and down and whether the floss around the tooth is practice. And one time, 60% floss around the tooth. That means 39.5% do not. Two times, 42.3% floss around the tooth. Three times, 35.7% floss around the tooth. Four times, 24% floss around the tooth. And more than five times, only 16.7% floss around the tooth. Overall, 39.5% of participants floss around the tooth, while 60.5% do not. What is the conclusion? The practice of flossing in the general population is very low. Almost 40% of individuals who report flossing do not practice the proper technique of flossing around the tooth. Compliance with regular flossing is low, with only 10 to 30% of patients flossing regularly. Recommended best practice, the S3 guidelines. These are the 3 steps for superior supragingival biofilm control. Mechanical cleaning is essential. However, patients may also require supplementary measures to effectively control supragingival biofilm and gingival inflammation. The infographic from the European Federation of Periodontology in 2020 highlights 3 key recommendations for oral health. The first one being brushing. Toothbrushing is recommended as a primary means of reducing supragingival biofilm. Interproximal cleaning. Interdental cleaning devices such as dental floss are recommended for cleaning interdental, supragingival, and subgingival areas not reachable by a toothbrush. Chemical agents. Adjuncts such as mouthwash may be considered to control plaque, the main cause of gingival inflammation. Essential oil mouthwashes are amongst the most efficient agents for reducing plaque, which is the main cause of gingival inflammation and periodontal disease. Essential oil mouthwash, role and benefits in oral health. Eucalyptus essential oil exhibits an antimicrobial activity against a wide variety of organisms. Its components include 1.8 cineol, p-cymene, cisgeraniol, and terpinolene, and can enhance the permeability of cytoplasmic membrane by causing functional impairment. Menthol exhibits relatively weak antimicrobial effects on its own, but demonstrates synergistic properties when combined with other essential oils, thereby enhancing germ-reducing activity. Additionally, menthol is valued for its pleasant mint flavor and its ability to impart a sensation of coolness. Thymol essential oil exhibits significant bacteriostatic activity against both gram-positive and gram-negative bacteria. This activity is primarily attributed to the high content of thymol and carvacrol, which are capable of forming hydrogen bonds with active sites of various enzymes. Methyl salicylate, identical to the compound found in natural wintergreen, is incorporated into mouth rinse formulations for its antiseptic properties. Additionally, it is frequently used in chewing gum due to its fresh flavor. Essential oils exhibit a multifaceted mode of action. At high concentrations, they cause disruption of the cell wall and precipitation of cellular proteins. At lower concentrations, they lead to an inactivation of essential enzymes. Owing to their small lipophilic structures, essential oils possess a significant potential for deep penetration into dental plaque. Bacterial biofilm. The formation of bacterial biofilm enhances resistance to antimicrobial agents. This resistance is attributed to the reduced metabolic rates of bacteria within the biofilm compared to their planktonic counterparts, as well as the impaired diffusion of antimicrobial agents, which limits the access of active ingredients to the bacteria within the biofilm. Formulations exhibit similar bactericidal activity against planktonic bacteria and may show significantly different efficacies when tested against the same bacterial strains in the biofilm form. Therefore, To ensure that the active ingredients can effectively target plaque bacteria, it is essential for formulations to possess the ability to penetrate the biofilm matrix. According to a study entitled Antiseptic Mouth Rinse Induced Microbial Cell Surface Alterations by Cabot in 1993, essential oils damage the walls of microbes. The study aimed to determine the effect of essential oil-containing mouth rinse on microbial cell surface morphology utilizing scanning electron microscopy. 24-hour cultures of Candida albicans, Actinomyces viscosus, Streptococcus sangus, Fusobacterium nucleatum, and Aggregatibacteria Actinomyces comitans were immersed in either essential oil mouthwash or a buffer for 30 seconds. What do they find? A 30-second exposure to an essential oil-based mouth rinse, which simulates in situ conditions, can significantly alter cell surface appearance of various microorganisms. These findings imply that clinical efficacy of a mouth rinse is primarily mediated through the damage of microbial cell surfaces, leading to cell death. Let's look at biofilm penetration. By looking at the article, Effects of Antimicrobial Agents on Oral Biofilms in Saliva-Conditioned Flow Cell by Foster et al. In 2004. The study aimed to assess the different antimicrobial agents on biofilms. After a 30-second exposure to various antimicrobials, the biofilms were stained using the live dead bacterial viability kit, which visualizes the integrity of bacterial plasma membranes. A green fluorescent stain indicated intact plasma membranes, while a red stain indicated cells that have sustained membrane damage. The results after examination of the biofilms treated with essential oil for 30 seconds demonstrated widespread membrane damage comparable to that observed in biofilms treated with 70% ethanol. Confocal micrographs of the biofilm indicated effective penetration of both the antimicrobial agent and vitality stains throughout the growing biofilm. Let's engage with the article, Effects of 6 months use of an antiseptic mouth rinse on supragingival dental plaque microflora by Minna in 1989. The objective of this study was to ascertain whether long-term use of antiseptic mouth rinses results in an unfavorable succession of oral pathogens or the development of resistant microbial forms. Participants rinsed with either an essential oil mouth rinse or 5% hydroalcohol control for the duration of either 3 or 6 months, after which microbial cultures were analyzed. What were the results? No significant intergroup differences in microbial counts were observed. Analysis of the data for treatment effects relative to pre-treatment levels did not reveal any significant changes. Furthermore, no significant increases were detected in presumptive oral pathogens, including spirochetes, Bacteroides, Streptococcus mutans, Candida albicans, indicating that no resistance had developed. Conclusion: long-term 3 to 6 months of an essential oil mouthwash twice a day did not cause a meaningful shift in the microbial composition or emergence of presumptive oral pathogens. We will now delve into the article entitled Comparative Antimicrobial Activities of Antiseptic Mouth Rinses Against Isogenic, Planktonic, and Biofilm Forms of Actinobacillus actinomycin comitans, AA as I will now call it, by Fine et al. In 2001. To assess the antibacterial efficacy of 3 mouth rinses formulations against isogenic strains of Actino or AA, including the variant that forms resilient biofilms in laboratory conditions and a spontaneous version that grows as individual cells. What was the objective of the study? To examine the impact of using an antimicrobial mouth rinse containing essential oils on the levels of subgingival bacteria in individuals with mild to mediate periodontitis. The study design: a study was conducted using a randomized, double-masked, controlled 2x2 crossover design. The strains were subjected to a 15-second exposure to one of the following things. So a phosphate buffered saline, which is the negative control, a mouthwash incorporating essential oils, a mouthwash with amine fluoride and stannous fluoride, and a mouthwash that contains triclosan, and PVM and MA copolymer. All three mouth rinses demonstrated a statistically significant reduction of 99.9% in planktonic strains compared to the control group. The impact on the biofilm morphologies of the organisms exhibited variability. The use of the essential oil mouthwash resulted in significant decrease in biofilm strains of 98.20% to 96.47% respectively compared to the control group. These reductions were statistically significant. The comparative mouthwash resulted in significantly smaller decreases that were not statistically significant. In the study, it was discovered that essential oil mouthwash was considerably more effective than the other mouthwashes in reducing dental plaque. This finding was based on the use of homogeneous biofilm model. The study's efficacy results clearly demonstrate the resistance to antimicrobial agents that biofilm formation confers, as it effectively targets both biofilm forming and planktonic strains of the same organism. Effect on disease-causing bacteria. The composition of subgingival flora can be influenced by the nature and the amount of supragingival plaque. An essential oil-containing mouth rinse has the potential to impact subgingival bacteria by altering the quantity and bacterial composition of supragingival plaque. Let's look at the literature. Examining the impact using a mouth rinse containing essential oils on subgingival periodontal pathogens by Fine et al. In 2007. The objective of the study was to examine the impact using antimicrobial mouth rinse containing essential oils on the levels of subgingival bacteria in individuals with mild to moderate periodontitis. The population of the cohort were adults in generally good health who have periodontitis, with at least 4 sites having a probing depth of 4 to 7 millimeters, a minimum of 16 natural teeth, and are affected by subgingival bacteria. What did they find? In just 2 weeks of using essential oil mouthwash, there was a noticeable decrease in the levels of periodontal pathogens found in plaque among both healthy individuals and those with periodontitis. In conclusion, using a mouth rinse containing essential oils can effectively combat the growth of harmful bacteria that cause periodontal diseases. The mouth rinse primarily disrupted the contiguous supragingival plaque, resulting in an antimicrobial effect. Long-term protection against plaque and gingival conditions. A systematic review was conducted to investigate the impact of a mouth rinse containing essential oils on dental plaque and gingivitis over an extended period of time by Stoken et al. In 2007. Research has shown that using essential oil mouthwashes can effectively decrease bacterial presence and minimize plaque formation in difficult-to-access areas. Multiple studies have demonstrated the long-term benefits of this treatment in preventing gingival conditions. The purpose of the study was to systematically gather and evaluate available data on adjunctive effect of essential oil antiseptic on plaque and parameters of gingival inflammation in the studies lasting more than 6 months. The population of patients in the study, the eligibility criteria for the patient population included being in good health, being at least 18 years old and having gingivitis without severe periodontal problems, and undergoing essential oil intervention, meaning using an essential oil product. The measured outcomes would include gingivitis and plaque levels. What did they find regarding gingivitis? Regarding gingivitis, the meta-analysis finding showed that regardless of measurement used, essential oils led to a significant reduction in gingivitis. The meta-analysis demonstrated a significant reduction in plaque with the weighted mean difference of 0.83 following the use of an essential oil mouth rinse compared to a control mouth rinse. The result indicates that the essential oil mouth rinse was significantly more effective in reducing plaque levels than the control mouth rinse. The weighted mean difference of 0.83 suggests a notable decrease in plaque accumulation, which is likely likely contributes to improved gingivitis scores, as plaque reduction is a key factor in managing and preventing gingivitis. In conclusion, it is important to note that even the most diligent patient may not be able to comply and completely remove plaque. When used alongside regular oral hygiene practices, an essential oil mouth rinse has been found to effectively reduce plaque and gingivitis, surpassing the results of the placebo or the control. Remineralizing tooth enamel. The remineralizing effect of an essential oil fluoride mouth rinse in an intraoral caries test by Zero et al. In 2004. Several factors can affect the effectiveness of fluoride in preventing tooth decay. These include concentration of fluoride, pH levels, how often the treatment is administered, the amount of fluoride used, and the duration of treatment, and whether an antimicrobial agent is added. The study aimed to assess the remineralizing effect of a new mouth rinse that combines fluoride and essential oils in an oral caries test model. Using an essential oil mouth rinse or a negative control used twice daily for 14 days. The recommended treatment regimen, as I mentioned, is twice daily application for a duration of 14 days. And the treatments used would be a mouth rinse containing essential oils and a mouth rinse containing non-essential oils with fluoride, and a non-fluoride mouth rinse with essential oils. This is our negative control. A total of 153 adults who were in good oral and general health were included in the study. These participants were wearing a mandibular removal partial denture, and 2 partially demineralized human enamel specimens were mounted onto it. The outcomes measured, there were 2 outcomes measured. One was the change in the mineral content expressed as a percentage of surface microhardness and recovery, and the other one was fluoride absorption. Comparison of recovery of surface microhardness. After a 2-week period, the essential oil mouthwash with fluoride showed a 42% recovery rate for surface microhardness. The positive control group had a 36% result, while the negative control group had a 16% result. Fluoride uptake in enamel. All 3 treatment groups showed an increase in enamel mineral content compared to their initial values. The fluoride uptake of the essential oil mouth rinse and the positive control mouth rinse was found to be significantly higher compared to the negative control mouth rinse. Additionally, the test mouth rinse demonstrated comparable effectiveness to the positive control mouth rinse. In conclusion, a mouth rinse containing 100 parts per million fluoride has been found to effectively promote enamel remineralization and enhance fluoride uptake. The use of fluoride and essential oils in a mouth rinse may offer benefits in preventing tooth decay, along with the already known effect of essential oils in reducing gum inflammation. The role of alcohol and its safety. Mouthwashes often contain alcohol, which serves as a solvent for active agents and as a preservative. A study was conducted. A meta-analysis was used to evaluate the likelihood of cancer development in individuals who use mouthwashes containing alcohol. Conclusion: insufficient data exists to support the claim that the use of mouthwashes containing alcohol has an impact on the development of oral cancer. Efficacy with or without alcohol. The effects of essential oil mouth rinses with or without alcohol on plaque and gingivitis, a randomized controlled clinical study by Lynch et al. In 2018. In order to assess effectiveness of 2 essential oil mouth rinses in reducing plaque and gingivitis, patients were instructed to either use mechanical oral hygiene alone or in conjunction with one of 2 test mouth rinses. One of the mouth rinses contained alcohol, while the other one was alcohol-free. The conclusion of the study was that both alcohol-free and alcohol-containing essential oil mouth rinses have been shown to effectively reduce plaque, gingivitis, and gingival bleeding. Importantly, there were no significant differences in the efficacy of the 2 formulations. This highlights the effectiveness of both types of essential oil mouth rinses in promoting oral health. Clinical evidence for the benefits of essential oils mouthwash, alone and as an adjunct to brushing and flossing to reduce plaque and gingivitis. The study entitled Adjunctive Benefit of an Essential Oil-Containing Mouth Rinse in Reducing Plaque and Gingivitis in Patients Who Brush and Floss Regularly, a 6-month study by Sharma et al. In 2004. A 6-month clinical trial was conducted using randomized controlled observer-blind parallel group design. The experimental groups were performing oral hygiene, the first group was performing oral hygiene by brushing and rinsing using a control mouth rinse. The next group performing oral hygiene by brushing, flossing, and rinsing using a control mouth rinse. And then the other group is performing oral hygiene by brushing, flossing, and rinsing using an essential oil mouth rinse. A total of 246 individuals who were in good health and had gingivitis were included in the study. The outcome measured was the mean modified gingival index. And the other one was to evaluate the extent of plaque using the Tereski variant of the Quigley-Hine plaque index. The gingival bleeding index is also measured to assess the severity of bleeding in the gums. Results of the study indicated that both the group that practiced brushing and flossing, as well as the group that practiced brushing, flossing, and then using an essential oil rinse, showed significant reductions in the mean modified gingival index scores, which I'll be now calling MGI, for the entire month compared to the group that simply brushed. The group that engaged in brushing, flossing, and rinsing with an essential oil solution shows statistically significant reductions in scores compared to the group that only brushed and flossed. Plaque scores showed significant reductions in both groups who brushed and flossed and the group that brushed, flossed, and used essential oil rinse, compared to the group that merely brushed. The brushing, flossing, and essential oil rinse group showed statistically significant reductions in whole mouth means plaque index scores compared to brushing and flossing group alone. The bleeding scores reveal the extent of bleeding, which is a crucial factor in assessing the health of gums. Both the overall oral mean bleeding index scores and the intraproximal mean bleeding index scores were found to be considerably decreased in all groups after 3 to 6 months. Conclusion: essential oils effectively infiltrate dental plaque biofilm, and the combined approach of mechanical and chemical therapy works in harmony to significantly decrease plaque and gingivitis. Using an essential oil mouth rinse twice a day, in addition to brushing and flossing, has considerable and noteworthy extra advantage. Let's look at the article, Efficacy of Flossing and Mouth Rinsing Regimens on Plaque and Gingivitis, a randomized controlled trial by Bosma et al. In 2022. The purpose of the study was to examine the effectiveness of professional flossing, supervised flossing, and mouth rinsing regimens in preventing and reducing plaque, gingivitis, and bleeding. A 12-week study was conducted at a single center with 156 participants. The study followed supervised examiner blind 4-arm parallel design with masked randomization. Measurements were taken at baseline, 4 weeks, and 12 weeks, 8 to 18 hours after using the product. The examinations that were done were the oral soft tissue tolerance, the 6-site modified Tereski plaque index, the Lobene modified gingival index, and the 6-site expanded bleeding index. Before the randomization process, subjects underwent a thorough dental prophylaxis. All subjects assigned to flossing groups were taught the American Dental Association's instructions on how to floss. The hygienist followed a standardized method for flossing, which was based on, again, the ADA technique. Both groups of participants independently performed flossing on their own during the week and weekends. Each group independently used their assigned products at home on a daily and weekend basis. The inclusion criteria for this study require participants to have some evidence of gingivitis without advanced periodontitis, be aged 18 years or older, with good general and oral health, and maintain adequate oral hygiene. Participants must have at least 20 natural teeth, with a minimum of 10 gingival bleeding sites, and be able to attend daily sessions during weekdays. So what were the treatment groups? So there were twice daily brushing. Each Each group had to have twice daily brushing. The first group also had to include a 5% hydroalcohol control twice a day. They're rinsing twice a day, flossing once a day, and flossing under supervision. The products that were used were the ADA reference toothbrush, the Colgate Cavity Protection toothpaste, an essential oil mouthwash, and unflavored wax dental floss. What were the instructions? Brushing for 1 minute twice a day, rinse with 20 ml of the mouthwash for 30 seconds twice a day, and follow the ADA How to Floss visual guide. The bar graph represents the plaque reduction rates for 3 different oral hygiene regimens compared to brushing alone, which was the negative control. The highest plaque reduction rate of 22.8% is observed with a combination of brushing and essential oil mouth rinse. The combination of brushing and professional hygienist flossing results in a 5% plaque reduction rate. The combination of brushing and self-flossing achieves a 2.5% plaque reduction rate. This data indicates that using an essential oil mouth rinse in conjunction with brushing is significantly more effective at reducing plaque compared to other methods evaluated. The table represents interproximal means for tooth plaque index at baseline and after 12 weeks for 4 different oral hygiene interventions that we've talked about. So the first one is the 5% hydroalcohol. The mean TPI decreases from 3.16 at baseline to 3.04 after 12 weeks. Essential oil mouth rinse, the mean TPI showed a significant decrease from 3.24 at baseline to 2.35 after 12 weeks, and it's marked with an asterisk to indicate statistical significance. Flossing by the hygienist, the mean TPI decreased from 3.02 at baseline to 2.89 after 12 weeks. Flossing under supervision, the mean TPI decreased from 3.19 at baseline to 2.97 after 12 weeks. What does this mean? Among the 4 interventions, the essential oil mouth rinse showed the most significant reduction in interproximal plaque over the 12-week period. The other methods also demonstrated reductions, though to a lesser extent, indicating that all methods provided some benefit in reducing plaque, with essential oil mouth rinses being the most effective. The bar graph in this slide shows the percentage of the reduction in the mean modified gingival index, MGI, at the 12-week compared to the control at week 12 compared to the control for 3 different interventions aimed at reducing interproximal gingivitis. So the essential oil mouth rinse achieved the highest reduction in the mean MGI with 46.6% decrease. Flossing by the hygienist resulted in a 26.4% reduction in mean MGI, marked again with an asterisk to indicate statistical significance. Flossing under supervision showed a 21.6% reduction in mean MGI, also statistically significant. What is the interpretation of this? The essential oil mouth rinse was the most effective intervention for reducing interproximal gingivitis, achieving nearly double the reduction compared to flossing by a hygienist or flossing under supervision. Both flossing interventions also provided significant reductions in gingivitis, demonstrating their effectiveness through a lesser extent than the mouth rinse. Again, if we look at the table, and it provides the interproximal mean modified gingival index, the MGI, at baseline and after 12 weeks for 4 different oral hygiene interventions. With the 5% hydroalcohol, the mean MGI decreased slightly from 2.40 at baseline to 2.34 at week 12. The essential oil mouth rinse, the mean MGI showed a substantial decrease from 2.48 at baseline to 1.26 at week 12. Flossing by the hygienist, the mean MGI decreased from 2.3% at baseline to 1.75 at week 12. And flossing under supervision, the mean MGI decreased from 2.45 at baseline to 1.84 at week 12. What does this all mean? The essential oil mouth rinse was the most effective intervention for reducing the interproximal mean MGI, demonstrating a significant reduction from 2.48 to 1.26. Flossing by a hygienist and flossing under supervision also showed notable reductions in MGI, though not as pronounced as the mouth rinse. The 5% hydroalcohol intervention exhibited the least reduction in mean MGI. These results indicate that essential oil mouth rinses are particularly effective in reducing gingival inflammation compared to other methods tested. Lastly, we look at the bleeding index, and the bar graph illustrates the percentage reduction in the mean interproximal bleeding index, the IBI, after 12 weeks for the 3 different oral hygiene interventions. With the essential oil mouth rinse, this achieved a 76.4% reduction in the mean IBI. Flossing by the hygienist demonstrated the highest reduction in the mean IBI with an 85.6% decrease. Flossing under supervision resulted in a 78%, sorry about that. Flossing under supervision resulted in a 78% reduction in the mean IBI. Again, what does this all mean? So we see flossing by a hygienist is the most effective intervention for reducing interproximal bleeding, with an 85.6% reduction. Essential oil mouth rinses and flossing under supervision also significantly reduced interproximal bleeding with reductions of 76.4% and 78% respectively. All 3 methods showed significant improvements, indicating their effectiveness in reducing interproximal bleeding, with professional hygienist flossing being the most effective. The summary: essential oils at the 12-week mark. Mouthwash produced a greater reduction in plaque compared to brushing alone, as well as compared to flossing conducted by a hygienist or supervised by a hygienist. Essential oil at week 12 mark showed the use of a mouthwash resulted in greater reductions in gingivitis, this is your MGI, and gingival bleeding index when compared to brushing alone. Supplementing a mechanical oral care regimen with an essential oil mouthwash proved to be more efficient in reducing supragingival plaque compared to the intervention of the dental hygienist using flossing. The next study we look at is the comparative effectiveness of toothbrushing, flossing, and mouth rinse regimens on plaque and gingivitis, a 12-week virtually supervised clinical trial. This was by Milliman et al. In 2022. The study aimed to see the impact of different combinations of supervised mechanical and chemotherapeutic regimens on plaque prevention and reduction. A 12-week study was conducted at a single center with a supervised examiner blind approach. The study followed a 4-arm parallel design and employed a masked randomized control trial with a total of 213 participants. At baseline, 4 weeks and 12 weeks, again 8 to 18 hours after the use of the product. Following the examinations, we looked at the oral soft tissue, the 6-site modified Turesky plaque index, the Lobene modified MGI, and the 6-site expanded EBI. Before randomization, all subjects received, again, complete dental prophylaxis, similar to the last study we discussed. Subjects assigned to flossing groups were taught the ADA how to floss instructions and demonstrated competencies. Flossing was performed once daily. The product use was supervised through video phone calls once daily on weekdays, with unsupervised use on the second daily and weekends. Intended sample size, there were 50 subjects per arm. The inclusion criteria for the study require participants to be between 18 and 60 years old, exhibit some evidence of gingivitis without advanced periodontitis, and have at least 10% of gingival bleeding sites. Participants must have a minimum of 20 natural teeth with scorable surfaces and maintain adequate oral hygiene and be able to attend daily virtual sessions for flossing and rinsing. Again, we look at the treatment groups with twice daily brushings, and then there was no treatment, flossing twice a day, rinsing twice a day, and then rinsing once a day, and flossing once a day and rinsing twice a day. The products again used, or what we did use, was the ADA reference toothbrush, the Colgate cavity protection toothpaste, the essential oil mouth rinse, and the unflavored wax dental floss. The instructions again was to brush for 1 minute twice a day, rinse with 20 ml of the mouth rinse for 30 seconds twice a day, and follow the ADA how to floss visual guide once a day. The bar graph illustrates the mean tooth plaque index, the TPI, for different oral hygiene treatments over 2 time points, week 4 and week 12. So in week 4, for brushing only, the mean TPI is 2.83. For brushing and rinsing, it's 1.86. For brushing and flossing, it's 2.9. And for brush, flush, and rinse, it is 1.77. In week 12, we see the TPI is, for brush only, is 2.61. The mean TPI for brush and rinse is 1.8. For the brush and floss group, the TPI is 2.92. And the brush, floss, and rinse group, the TPI is 1.89. So what does this show us? The combination of brushing and rinsing consistently shows a significant reduction in plaque in both week 4 and week 12, with reductions of 34.2% and 35.6% respectively. The combination of brushing, flossing, and rinsing demonstrates the highest reduction at week 4, which is 37.4%, and a significant reduction at week 12. Brushing alone shows the least reduction in plaque, while brushing and flossing alone appears to increase the TPI slightly at both time points. This data suggests that rinsing, either alone or in combination with flossing, is highly effective in reducing plaque when used alongside brushing. Brushing twice daily, followed by rinsing with an essential oil mouth rinse, as part of an oral care routine, resulted in notable and long-lasting decreases in supragingival plaque compared to brushing and flossing. When used in addition to brushing and flossing, an essential oil mouthwash decreases interproximal plaque by 28.4% compared to using only brushing and flossing after 12 weeks. What is the interpretation of the graph? The combination of brushing and rinsing consistently shows significant reductions in plaque at both week 4 and at week 12, with a reduction of 26.2% and 26.9% respectively. The combination of brushing, flossing, and rinsing demonstrates the highest reduction in plaque at week 4. This was 29.5%, and a substantial reduction at week 12, which was 24.9%. Conversely, the combination of brushing and flossing alone leads to an increase in mean TPI at both time points, indicating it is the least effective method and may be counterproductive. This data suggests that rinsing either alone or in combination with flossing is highly effective in reducing plaque when used alongside brushing. The gingivitis scores. The bar graph displays the mean modified gingival index for different oral hygiene treatments at 2 time points again, week 4 and week 12. And we know that the different treatments is brushing only, it's then brush and rinse, it's then brush and floss, and then it's brush, floss, and rinse. And we're going to look at this over the 4-week and the 12-week time point. At both the week 4 and week 12, the combination of brushing, flossing, and rinsing demonstrated the highest reduction in the mean gingival index, with 51.1% at week 4 and 54.1% at week 12. Brushing and rinsing alone also showed significant reductions in mean MGI, with a 43.7% at week 4 and a 50.8% at week 12. Brushing and flossing alone resulted in the smallest reductions in the mean MGI, with 9.7% at week 4 and 9.2% at week 12. Brushing alone showed no significant change. These results suggest that rinsing, especially when combined with flossing, is highly effective in reducing gingival inflammation compared to brushing alone or brushing with flossing. Bleeding sites. The bar graph illustrates the reduction in bleeding sites, both for the whole mouth and interproximal areas, for different oral hygiene treatments at week 4 and 12 again. The combination of brushing, flossing, and rinsing demonstrated the highest reduction in bleeding sites at both week 4 and 12 for both the whole mouth and interproximal areas. Specifically, it achieved a reduction of 72.5% for the whole mouth and 77.1% for interproximal at week 4, and 78.2% for the whole mouth and 79.3% interproximally at week 12. The brush and rinse combination also showed a significant reduction in bleeding sites, with 59.3% at whole mouth and 61% interproximally at week 4, and 71% whole mouth and 68.7% interproximally at week 12. In contrast, the brush and floss combination demonstrated the least reduction in bleeding sites, with only 12% whole mouth and 9.2% interproximal at week 12, and 17.5% whole mouth and 16.1% interproximally at week 12. These results suggest that the addition of rinsing to brushing and flossing regimens significantly enhances the reduction of bleeding sites, with combined approach of brushing, flossing, and rinsing being the most effective. Conclusion: the study found that using an essential oil mouthwash, in addition to brushing twice daily, resulted in a significant and long-lasting reduction in plaque. The study found that using an essential oil mouthwash, in addition to brushing twice daily, resulted in a significant and long-lasting reduction in plaque on the surface of the teeth, compared to just brushing alone. Utilizing mechanical oral health care routines consisting of brushing and flossing, followed by rinsing with an essential oil mouthwash twice a day, resulted in notable and lasting decreases in supragingival plaque compared to brushing and flossing. We're going to look at another study quickly by Bosma et al., and the results are very similar to the last study that we discussed by Bosma et al. In 2022. This is just a further study done in 2024. This study aims to investigate the effects of combining mechanical oral hygiene methods, brushing and flossing, with chemotherapeutic regimens, including essential oil, non-alcohol, and alcohol-containing mouth rinses, compared to brushing only. The focus is on preventing and reducing plaque and gingivitis. The parameters that were looked at was gingivitis again, bleeding, plaque index, and probing depths, again at baseline and at week 12. Participants for the study must have some evidence of gingivitis without advanced periodontitis between the ages of 18 and 60 and have at least 10% of gingival bleeding sites. They should maintain adequate oral hygiene, have a minimum of 20 natural teeth, and be able to attend daily virtual sessions again for rinsing and flossing. The effect of flossing and mouth regimens, the efficacy of flossing and mouth rinsing regimens on plaque and gingivitis, a randomized controlled trial by Bosma et al. Had 5 types of treatment groups, all in conjunction with twice daily brushing. The products used again was the ADA reference toothbrush, the Colgate protection toothpaste, the essential oil alcohol-containing mouth rinse, and essential oil-free mouth rinse, alcohol-free mouth rinse, and unflavored wax dental floss. Again, the instructions were the same as for the other 2 studies. It's brush for 1 minute twice a day, rinse with 20 ml of the mouth rinse for 30 seconds twice a day, and follow the ADA How to Floss visual guide. Plaque scores following a 12-week treatment period. Mouthwash with essential oils and no alcohol is far more efficacious in combating plaque compared to relying solely on brushing and flossing. After a duration of 12 weeks, individuals who utilized essential oil mouthwash without alcohol in conjunction with brushing had a reduction in interproximal plaque scores that was 18.2% more than those who only brushed and flossed. Furthermore, the group that brushed, flossed, and rinsed with essential oil mouth rinses without alcohol saw a reduction in interproximal plaque scores that was 16% greater. The group that used essential oil mouthwashes without alcohol experienced a 23.9% greater reduction in whole mouth plaque scores compared to those who simply brushed and rinsed. Additionally, the group that brushed, flossed, and rinsed with essential oil mouthwash without alcohol had a 21.6% greater reduction in plaque scores compared to those who only brushed and flossed. Results of gingivitis assessments following a 12-week treatment period. Alcohol-free mouthwash with essential oils is considerably more efficacious in combating gingivitis compared to relying on just brushing and flossing. After a duration of 12 weeks, the scores for interproximal gingivitis decreased by 36.9%, more in individuals who used essential oil mouthwash without alcohol, in addition to brushing, compared to those who only brushed and flossed. Furthermore, the group that brushed, flossed, and rinsed with essential oil mouthwash without alcohol experienced a reduction of 36.1% in interproximal gingivitis scores. The group that used essential oil mouthwash without alcohol for brushing and rinsing experienced a 43.3% greater reduction in whole mouth gingivitis scores compared to those who did not use mouthwash. Similarly, the group that brushed and flossed and rinsed with an essential oil mouthwash without alcohol had a 41.5% greater reduction in scores compared to those who only brushed and flossed. Conclusion: an oral healthcare regimen of brushing, then rinsing twice daily with a non-alcohol essential oil mouthwash provided significant reductions in supragingival plaque, gingivitis, and bleeding versus brushing alone versus brushing and flossing. Using dental floss once daily after brushing had no effect on supragingival plaque reduction and gingivitis at 12 weeks, but significantly reduced bleeding. Utilizing dental floss once daily after brushing did not result in a decrease in supragingival plaque or gingivitis after 12 weeks. However, it dramatically reduced bleeding compared to brushing alone. So in summary, essential oils has a significant capacity to deeply infiltrate dental plaque owing to their tiny lipophilic structures. A 30-second exposure to an essential oil mouth rinse can significantly alter the appearance of cell surface of certain oral bacteria. Essential oil-based mouth rinses does not disturb the natural balance of microorganisms in the mouth and does not lead to the emergence of resistance. The use of an essential oil mouthwash is shown to be successful in reducing dental plaque in both the homogeneous supragingival biofilm model and the representative periodontal pathogens. An essential oil mouth rinse, when used consistently as a supplement to regular oral care, offers long-term protection for gums by reducing plaque and gingivitis. Essential oil mouth rinses that contain fluoride is a useful tool for enhancing the process of enamel remineralization and increasing absorption of fluoride. Additionally, it has the potential to effectively prevent tooth decay. A mouthwash containing zinc chloride effectively minimizes the accumulation of calculus in those with a moderate propensity for calculus formation, hence preventing potential tooth discoloration. The concurrent use of mechanical and chemical therapy in conjunction with an essential oil mouth rinse exhibits a synergistic effect in diminishing plaque and gingivitis in interdental spaces. And with that, I thank you. We've come to the end of our presentation. I'm going to stop sharing my screen.
Thank you very much, Dr. Singh. Yes, there was a lot of research tonight, and that is what it was all about, was sharing the science about essential oils in mouth rinses.
Yes,
and you did it so
absolutely.
wonderfully. We only have one question, and it's from Anonymous, and it says, does castor oil in mouthwash have antimicrobial properties?
Sorry, does?
Castor oil
In mouth rinse.
in
Okay, so
in a mouthwash, yes.
in a mouthwash, castor. I haven't come across castor oil in a mouth rinse, and I'm happy to research that a bit more and provide this participant, if they provide you their details, with a concise, more scientific answer.
Correct. Are there any other questions? We've got Dr. Singh here, and we have probably another 13 minutes. So we would love to answer any more of your questions. What I found fascinating while we're waiting for more questions to come in was the slightly difference between an essential oil with alcohol and essential oil without alcohol, and the difference of that. That was in Bosman 2024, which is
Yes.
a really recent study. The science does show that the non-alcohol does have a slightly more
Very
efficacious thing. Yeah. So, and we have some more questions. Thank you very much.
okay.
Coconut oil and teeth whitening, quite a media frenzy. Any truth in that?
So I don't know about coconut oil and tooth whitening, but there is some effectiveness shown for coconut oil and oil pulling. It has been shown to reduce gingivitis, but very minimal. And we can look at a study by Peng et al. In 2022, and their data shows that or using coconut oil or oil pulling may have beneficial effect, as I said, on reducing the bacterial colony counts, but does not significantly affect like plaque index and gingival index scores. And this was a meta-analysis done. So it doesn't really talk much about tooth whitening effects of coconut oil, but it has been shown in oil pulling, and it does have some benefits there.
Thank you very much. And if that person would like to give their name to SADA, to Marilise, I'm sure Dr. Singh will be able to share that
Yes, I can share the
research
study.
with you. Correct. We do have another few questions coming in. Thank you very, very much. What do you feel about tea tree and lavender oils?
Both again shows antimicrobial properties, and tea tree oil is shown to reduce inflammation quite a bit, and it does have its potential uses in mouthwash and toothpaste. But again, we must go with the science, and it must include all the other important ingredients. We can't simply just go herbal alone. We do need to include the other ingredients that form the basis of toothpaste and mouth rinses. So yes, they all
Thank
have
you.
a place, and they do have a inflammation reducing properties.
The next question is, have you seen studies comparing essential oils to hydrogen peroxide?
So hydrogen peroxide is a bleaching agent, I'm correct, yes. And essential oils is used for reducing inflammation, as we've seen, reduction in gum disease, giving you a healthy mouth. So no, I haven't really seen studies with hydrogen peroxide. I'm unclear on this question. What do they want to know about hydrogen peroxide?
Comparing essential oils to hydrogen peroxide. So have you
Okay,
seen any
again,
studies like that? Yes.
no, I haven't actually come across any study like that. But again, I'm happy to provide more details if I do find such a study to the participant.
Sure. Sure. And then the next one, thank you for a great presentation. Will a recording be available? Would like to recap. There was a lot of information. Yes, so I'm going to speak to Sada, to Marilise, and I'm not 100% sure, I don't know about you, Dr. Singh, whether the recording will be available, but we can
I
always
think it
find
will
out.
be on YouTube, if I'm not mistaken.
Okay,
There's always a recording on YouTube after the presentation is done.
great. Well, there's the answer. Go on to YouTube. What about, next question, what about homemade recipes? I have a lot of natural patients. Can it be mixed with sodium bicarbonate or salt? I think we're referring to probably a mouthwash with sodium bicarbonate or a mouthwash with salt.
For these sort of patients, we don't want to tell them not to use products that they believe in, but we must also advise them to use it in conjunction with products that have scientific backing. So if they want to use the sodium, the bicarbonate of soda in moderation, obviously they can't go now and mixing a whole bottle of it or a box of it. So everything must be backed with science. If the science shows that it can be used in conjunction with each other, then yes. So as a practitioner, we must always be very aware of the science. And if we asked such questions, don't just answer on a whim. Let's do the research together with the patient sometimes and show them what actually works and what actually doesn't. Once provided with evidence, they can then make an informed decision as to what they want to use. So I always
Great.
believe education is key, and it's our duty as practitioners to educate our patients with scientific evidence.
Yes, yes, I agree. Which mouthwash is most effective for halitosis?
So I can't actually name any mouthwashes on this platform, but we will get back to you on email if you just leave your details with Barbara, please.
Correct. They can leave their details with perhaps with Marilise, and then
Yes,
Marilise can
that would be
forward it to
fine.
me. That would be
Yes, this
great,
is a
or put
CPD
it
event, and we
on.
can't discuss
Correct. Correct. So info at
brands.
sada.co.za or pr@sada.co.za. Please pop an email through and we'll be very happy to answer that question.
Absolutely.
Hello. Some patients come in not brushing their teeth, but they say they use a mouthwash. So is that a disadvantage? And what manner do you deal with a patient like that?
So yes, we know from listening to the study that it must be done, listening to the seminar, it must be done in conjunction with each other. So we must, so each one on its own has some benefit, but not a significant benefit as when they're done together. So again, we always go back to educating our patients, and we have to show them what we know. So in the form of pictures, you show them what's brushing alone. Then you can show them what happens if you use mouth rinsing alone. And now you are armed with studies that we have from this seminar to show your patients that you can't only use a mouth rinse, you have to use it in conjunction with brushing, with flossing. And that's that 3-step by the periodontist that give you the greatest benefit. So everything has to happen synergistically and together.
Thank you
Again,
very much.
it's always about, and I don't know, it's because I come from a community dentistry background, but it's always about prevention and it's always about education. And education is extremely important with our patients. The more we have it, the more we have these displays in our waiting rooms, the more we have information available to them on our websites, the better it is for them. And eventually it will drive home that everything happens in conjunction, what's good, what's bad, but nothing works if we don't have evidence to back up what we are saying.
Thank you. And I see we are 1 minute over. So there are a few other questions. Orlando wrote us. I hope I'm pronouncing your name correctly. And Shirley Porn Lim. I will ask Marilise or Ruth after this for your questions, and then we can always send you an email after this. So, Dr. Singh, thank you so very much. And thank you for all your participation to the delegates and your interactive questions and the answer session. Just a reminder, and this comes from SADA, that there is 1 month to go to register for the SADA Dental and Oral Health Congress and exhibition in Pretoria this year. If you have not yet done so, the website is www.sadacongress.co.za. Kenview will be there at stand G1, and I look forward to personally welcome you. Please come to our stand, and I'd love to meet you face to face. So this is the close of the webinar. Reminder, please, to complete the evaluation form. And from SADA and Kenview, we wish you all a very good evening. And thank you for joining us.
Thank you,
Good
and have a
night.
good night all.
Thank you so much, ladies. What an interesting webinar.
Thank you so much for having us.
You're
And if you
welcome.
could just please forward me the details of everyone that needs a response.
Will do so. I will do so.
All right. Thank you, Barbara.
Okay.
Thank you, Ruth. Good night.
Thank you so much
Yes,
and have a
thank you,
great night.
Dr. Singh.
Thank you.
And good night too. Pleasant
Night,
evening.
Good
everyone. Thank you.
night.
Bye.
Bye-bye.
Thank you. Good night. Bye-bye.